economical models. You have these two parts. Why these two parts are related? Because mainly when we ask, when policymakers ask us the questions, we need to understand what is his aim and why he asked these questions, in order to try to give a good answer to what we need. So just before beginning, as I said, we'll try to understand what does it mean by policymaker, what is his aim. So by definition, when we deal with epidemiology, we deal with public health. And when we speak about public health is the science and practice of preventive disease, prolonging life, promoting health through organization effort, and informed choice of society, organization, public and private sector. So mainly public health is about population focus. With this definition, we need to deal with population, not individual. Preventing, our goal is preventive, as for example a mass vaccination campaign. It can be, it's not like a medical action, which is individual, curative, and for example treating one individual. Treating one individual is about the individual. Public health is about population. And as it's about population, it's about the individual itself is less important than treating the population as a whole, whatever it's, even if it has an impact. And this idea is very important for us, because when we put vaccination campaign, if you put a vaccination campaign, perhaps the vaccination campaign will not reach everyone, because it's not cost effectiveness. And for sure, in some case, some people will not be vaccinated, because, as I said, it's not, the strategy is not really cost effectiveness, and therefore, as a public health action, it's not something important for us. The individual is not important. The population is more important than one individual. So, what are our purpose? Is to generate scientific and support public health decisions. What does it mean? It means that how will epidemic evolve in the coming month? This is one example of question. What vaccination coverage is needed for herd immunity? Which vaccine should be prioritized based on effectiveness and context? As you see here, you have mass vaccination coverage. You have which vaccine should be prioritized based on effectiveness and context. The notion of effectiveness and context is something that we need to redefine, and redefine as in the sense of public health, or in the sense of the economy. And the context is the context where the system and the vaccination will be applied. So the challenge is a persistent misunderstanding. So generally, you have persisting misunderstanding between academic, where the field where we belong, and the world of political decision. And sometimes the world of political decision do not have, how can you say it, the action that is taken by policy maker generally is taken because of the economy, or because of political fact, better than health fact. Even if the health action is something important, because it Minister of Health generally is someone who belongs to medical doctor, and his point of view is mainly a point of view of a medical doctor. So, what type of decision maker you have? You have Ministry of Health. Well, so what type of decision? Yeah, you have a decision Minister of Health, of course, Minister of the Economy, Prime Minister, Parliamentary. You have also head of national agency, like public health institution, and you have local authorities, regional health agency, governor, mayor, technical expert, scientific committee, like UNICEF, WHO, Médecins Sans Frontières, and all of them. All these one are what we call the decision maker. And when we speak of a decision maker, we speak of these 3 levels, these 4 levels, depending on where you are. Each category faced to a specific constraint and priority. Mainly, the goal that we have is to understand how decisions are made and what interests are limitation each actor faces to a social effective communication. Generally, what we hear when we say that when we deal with one of them, we need to understand them. We understand what they need, what they want, and how the limit that we have. Depending on where you are, which level you are, in the top levels or in the local levels, depending on you. Also, I gave you an example of public health decision-making pyramid during COVID-19. During COVID-19, Tunisia, the pyramid of decision, in the bottom, you have what we call the operational structure of the ministries. The operational structure of the ministries is where the decisions were applied, and not where decisions were decided. In the top of this, you have a ministry, commission, and scientific society. And the ministry, commission, scientific society do not take decision, take a recommendation, and make the recommendation to the ministry. And there you have the restricted council of ministers. What I call the restricted council of ministers is the health ministry, the economic ministry, the interior ministry, the defense ministry, social affairs. And these 4 ministers, taking the note, knowing that what was done in the scientific society, decide to take one decision or the other. I will give you examples. And the top of them, you have the prime minister. The prime minister is the person who takes the decision. I will give you example what happens in Tunisia. During COVID-19, they decide very early to not do nothing, to do nothing. I mean, after the first wave, where you have a curfew and you have restriction for movement, and after that, they decided, it was in March 2020, they decide to stop doing anything. And the only thing that you have to do is a little bit to stop the epidemic in order to not overcrowd the hospitals. This decision was taken here. And this decision was taken between the Minister of the Economy, the Prime Minister, and the Minister of Health. The Interior Minister gave his opinion regarding the way of the trouble, how to apply the no measure that they will be asked. And this decision was not given, was not explained to the people. Nobody knows that. And mainly nobody knows that because the decision, the political decision to not say anything was an answer to the people who are waiting for any action. And the action that was taken was mainly curfew between midnight and 5 o'clock in the morning, curfew during the weekend. It's very small action with no public health sense. And that's why I'm saying there is no really action, no action. At that moment they decide to take no action even if the Ministry Commission say that we need to have a strong action in order to stop the COVID-19. But the decision was taken here. And this idea is very important because we, as a modeler, even if you say that this action is very good or this one is better than the other one, you need to know that even what we said is not followed. It's not because it's not a true one. It's just because the decision is taken in another place. And the other place has other arguments to take the decision that the public health decision. And knowing this, it helps us to know what are our frontiers, what we can do, how to measure our success. Measuring our success by applying the decision that the modeler asked is not something that can be, it's not a good measure. mainly because, as I said, the decision is not taken here. The decision is taken here. These three main groups, what we need also to understand that this is main group of the three main groups of decision, public health decision, which are the data generator. What I call the data generator is the structure that generate data. These structures that generate data are hospital, public health observatory, local health center collect, organize, reporting, create data. These data are the foundation for the situation awareness and epidemic analysis. The second element are the policymaker. The policymaker is a group that includes the Minister of Health, Director General of the Health, senior governor authorities. They are responsible for making the final decision of integration specific scientific recommendation. And the last one is that what I call the evidence producer, is the experts such as modeler, epidemiologists, and statistics who analyze the data and generate facts. So these three elements are the three elements that make the what can I say it? That produce for case that produce argument to take the good decision. What we have is if you go to Western countries, generally the difference between these three elements are very clear. What are the data generator, what are the policymaker, what are the evidence producer, and this, the fact that you have a clear difference between them, it makes that the thing can work quite in a good way. The data generator generates the data, and the evidence producer can use this data in order to produce their facts. The fact for example, in Tunisia, the relationship between this one and this one are not clearly stated. The data generator do not, even if they produce data, they do not publish the data. They do not make their data available to the other, for many reasons. And so the evidence producer need to deal with these facts. And sometimes you have policymaker are mixed between, you have a mix between policymaker and data generator. The policymaker, the data generator belong to the circle where the decision is taken. And in this situation, you can have some problem of how can I say it, the decision, when the decision is taken, is not taken only because of interest of the policymaker. Is also depend on when you are this mix, the policymaker who decide the politics is the one that measures the impact of his politics. And if you have this mix of roles, it makes that the decision is not taken only because of public health action, public health purpose, is made also because of political purpose. So, as I said, data generator are the group the people the public health observatory, the basic care directory, hospital, and so on. They collect, structure, and report epidemic and operational data and provide raw input necessary for public health analysis. Why they matter is because a high quality, complete, accessible data is essential for making good models. And this fact is very important. Who are there? What are they doing? How do they work? The evidence producer, who are modeler, epidemiologic, statistician, and health analysis. They analyze the data and create models, analyze statistics, and translate data into insight, scenario, policy, and option. They reduce the uncertainty and generate action and evidence to guide public health response. So here, the role that we have and the limit of the role that we have is defined here. And it's very important for us to not cross this road. Evidence consumer, they are the minister, the elected office, the elected official, director of public health of the public health agency, and other decision makers. They interpret and act upon evidence-based recommendation and they get scientific input with political, financial, and social constraints. And they decide. So they are paid to decide. They are paid to take all this information and to decide what is good, what is bad, as a public health action. So here I gave you a maps of the Tunisian ecosystems. In the Tunisian ecosystems, you have here the hospitals, all the structure that generate what I call the dataset provider. And these dataset providers are connected with a really dataset that are put in dataset bases. They are related with the modeler and the epidemiologist. So you are here and you are here. This is epidemiologist groups that give advice to the Ministry of Health. You have a lot of committee here dealing with different type of disease. You have the HPV committee, you have the maternal care committee, and so on. A lot of committee here who take this data and treat them. And these one are related with the policymaker, which are the director of different organisms, the basic care committee, the Ministry of Health, and so on, who take this data and to take the analysis of this data that are made here to take the decision. And then you have a go back. However, if you look at the, let's go. If you look at the if you analyze the interest of different people, you see that the politic interest in public image, electoral strategy, and also social interest as public opinion. However, scientists are interested in publishing paper, and these two of them can have opposite argument and opposite opinion and opposite goal for the. And what we need to do is to try to make this one and this one very near from the other. Sometimes you have conflict of interest, and this conflict of interest make that, for example, can pharmaceutical company closely link to scientific society. It gives you conflict of interest. Power dynamics, individual testing, analyzing strategy, who are also involved in decision making. This one can happen. For example, in Tunisia, is something that happened many times. You have the same people in different committee or different providing, as I said, different group of people providing data and also taking the decision on some disease. Scientists involved as a data generator. Here you have this is something that can happen in our countries where you have academics who take position in the ministry. So you have you are taking decision or giving data, but in the same way you are scientists. So you are not sometimes you take the data, you do not publish the data in order to use them as a scientific for scientific paper. And so you are not really data provider. You are not playing the role of data provider. You are more playing the role of scientist when it's sweet to you, and in other times you are playing a role of public health manager. And as I said, you have different logic timeline between the sector. So I will give you an example. Here, in the picture that I gave, here you have is during COVID-19. So it's the example, and during COVID-19 you have a press conference where you have scientists and policymaker. So this picture was made during the one press conference where you have scientists and policymaker. And I would like to, not the Tunisian, but the other, I would like to tell me who is the politician and who is the scientist. in this picture. Who is the scientist? Who is the politician?
The politician is the one speaking.
Sorry?
The one in the middle.
No?
In the middle, speaking.
Who is it? The politician?
Yeah.
Yeah. There is here you have the scientist and the Ministry of Health.
I'm guessing that there are two who are wearing masks and there's
Sorry?
There are two who are wearing masks.
Yeah?
And there's one who's not wearing a mask.
Yes?
So I think the scientist. No, that's where it gets hard.
The scientist
The scientist could be the one
would not get getting the mask.
wearing the mask. Scientists not wearing a mask, politicians wearing the mask.
And which one is the scientist? Which one of them is wearing the mask? The scientist is this one,
No mask. Mask.
and the other one?
Mask.
The mask.
Yes.
The politician. I'll give you the answer. This is the person who translates for the with how to say it? Yes. That's why he's not wearing a mask. This is the Ministry of Health. This is the scientist. And in this picture, I like this picture because it explains you exactly what I call the conflict of interest and someone who takes the position from the other. So what's happening here is, as you see, the politician, the Minister of Health, is letting the scientist giving his talk, explaining the fact, explaining what, as I told you, during COVID-19 they decided to do nothing. No action, and the action was totally without any sense. So this minister is putting the science is explaining decision with no sense, public health decision with no sense. So these scientists, are they here to explain something, to explain that having a curfew between 9 p.m. to 6 p.m. in the morning will have a huge impact on the dynamics of COVID-19, which is totally no sense. So she's explaining this. And he's waiting for her to explain something that scientifically have no sense. What are they doing this? Because his goal here is not take the responsibility of the action and putting the responsibility of the action on the scientists. Why the scientists are playing this game? Because these scientists would like to be minister and would like to involve in the trajectory as a political action. So she's taking the place of the minister because she's in front of the camera. And as she's in front of the camera, she's going to be the person who is more important. And of course, she would be. I mean, after that, she was the most important scientist in Tunisia. And this is what I call each one take the place of the other, and each one is winning. But what is losing, what we lost, is the fact that the science word, science argument would not have the same weight before COVID-19, after COVID-19, because of that. So, what we need to understand is what I call what is our boundary, what is our role and what is our boundary. Our boundary is to say what we say it is true. To have this confidence between when we speak with the policymaker, you know know the argument, you know what is true, what is false. The decision was taken. If the policymaker takes his decision, it needs to decide with fact and not with what we want him to say. And this is what I call making a trust environment. And making this trust environment, it means that you do not, you need to, what I say here, the ethic implication and the role of confusion is to protect scientific objectivity, ethical response in research and public health discourse. and distinguish between evidence produced and decision-making power. And finally, to maintain scientific integrity in the mediate and the politics. Even if this integrity, for having this integrity, we need not to discuss with the press. You need to know exactly where our road stops. And our road stops make our, what I call, our responsibility and our objectivity. So, what's the main decision between scientific and political logic in health? Scientific logic comes from long-term study, acceptance and uncertainty. It focuses on effectiveness, equity, and evidence. It makes a nuance between communication with a methodological approach. But political logic is take decision urgency, immediate preserve, message simplification, need to be persuasive, mobilize, and communication. And both of them cannot meet together. I mean, you know exactly the frontier of each one and know exactly what our role and responsibilities. What are the modeling challenges? As I said, the modeling challenge is to make these two worlds together. What our final objective is to understand the reason behind the existing phenomenon. In public health, is playing crucial equation to support decision making. However, these two things, for example, you can have for the final objective, what was the effect of vaccine introduction during the evolution of COVID-19 epidemics? And here, the same question is when and will the peak of the epidemic occur. Decision maker would like to hear this one, is local, apply, and operational solution. And as scientists, we need to have a global, theoretical, and generalized approaches in order to be applied. So, both of them are interconnected. To test a local solution is necessary to understand the evolution of the epidemic. And this is what we've done. When we got the project yesterday, the first thing that you begin to do is to write the models. What does it mean writing the models? It is to try to understand how the disease can be spread in the population. When you wrote the model, your goal is not to test the strategy, it's to understand how the disease is modeled, how it's spread in the population. As a corollary, you're going to have the action, testing the action that you have. So this is what I said, both are interconnected. To test local solution, it is necessary to understand the evolution of the epidemic as a whole. Example, to assess the effect of introduction of HPV vaccine, is crucial to understand how the virus spread into society. Modeling sexual behavior in a population. And the modeling approach can be individual, multi-agents, societal population based on compartment model. Whatever it is the model is, you need to understand how the thing works. And when you understand how the thing works, you can test whatever you want. What I said, the effective modelings, we need to understand social behavior population. You evaluate parameters of the disease, the life cycle of the disease. And the effective decision making need to have, give you constraint on the material, organization, culture, proposing a set of feasible solution scenarios. And I will stop here, about proposing a set of feasible solution scenario to explain what does it means. What I call feasible scenarios mean a feasible scenario as an economical point of view, but also as a societal point of view. If I go back for the action of Tunisian action during COVID-19, the proposed feasible scenario in the case of Tunisia was doing nothing. Doing nothing was the best decision that was taken in Tunisia. Because the cost of all the decision would not stop the epidemic, because the epidemic was in the entirety of the world, and they had no money, no budget for putting any action outside the action of doing nothing, or except that allowing that hospital is not to be crowded. This is what I call feasible scenario. Do I have the money to do it? Do I have the people to do it? Do I have the people who will accept the decision that I can take it? This makes a set of what I call the feasible scenarios. So I will stop here to give you the example. I will stop here to give you the example of HPV scenario example that we have in Tunisia. What we and it was not only in Tunisia, in Senegal. So the context is the following: the HPV vaccination was introduced in Tunisia last year, and Tunisia is a North African country, as I said, and you have not a lot of women having a cervical cancer. The cervical cancer for women is the third cancer for women. So we decide to introduce the HPV vaccine in the shuttle in April 2025, targeting 12 age old. So the other thing that we need to understand, that in Tunisia, vaccination is all girls need to make her vaccine. There is no. The vaccine is made in the school, and you are not allowed to not make the vaccine. However, only 4% of eligible girls have been vaccinated. So it means that you have a very strong campaign against the vaccine. As I said, all the vaccine is mandatory. However, you had a huge girl and the family of the girl decide to not allow the girl to make the vaccine. So the key question that was asked by the Minister of Health for us was, what were the public perception and opinion before the introduction of the vaccine? Before the introduction of the vaccine, they wanted to understand what are the opinion of the girl. And secondly, what is the most effective strategy of vaccination, cancer screening, and a combination of the two factors? They need to decide what type of vaccine they wanted to use. The third one is what are the main barriers leading to low vaccination uptake. So these three questions, the first one is what happened before vaccination, what are the opinion? Second one, what is the most effective strategy? And third one, trying to explain why you have only 4% of eligible girls who were vaccinated. What happened in the population? So for that, we had a very long period of work, and this long period of work began in 2022. Knowing that the choice of working on HPV vaccine was not something, I can say, clear for the Ministry of Health. In fact, when we begin to think about working on vaccination strategy, I went to the Ministry of Health and asked them what are the main strategic vaccines they would like to introduce in Tunisia. And I made it I went to the Ministry of Health and asked him the question. And I made the same question to 10 different people who have some influence in Tunisia. And I had 12 vaccines. 10 people, 12 vaccines. It means no one of them gave me the same answer. Going from a very vaccine that cost, pediatric vaccine that costs $100 per dose, to a vaccine, to flu vaccines, to all type of vaccine you can imagine that was given. And all of them, for the guy who I asked the question, who's something very influences, have a relationship with the policy maker taking the decision. And I explained you why his idea, his vaccine is the best one. And he said strategically is a good one we need to study. And why do I choose the HPV? HPV was said by nobody. Why I will choose the HPV? You can say, well, what will be the next vaccine will be introduced in Tunisia? They told me the HPV. Said, well, let's work on the HPV. Say, no, HPV, it's okay. We know how to do it. And everyone say, yeah, you know how to do it, and everything is okay, and we know which vaccine to choose, and so on. And just to give you an idea, we have 4% of eligible girls who was vaccinated, knowing that they know how to do it, and knowing the study that we've done. So why I'm saying this? Because the perception, the policy maker perception, what we know how to do it, is not really what the reality. The reality is something different. What the minister know what his counselor say to him, and what his counselor say to him is not something always something that is true as a modeling point of view. So, as I said, we begin in 2022, and then we select the HPV here. And it was in 2023, and then we begin to work. And we begin to work, all the steps, all the circle takes 1 year, knowing that in this year, the modeling part was 4 months. All what happens before that is only workshop meeting with policymakers, explaining what we are doing, explaining each steps, explaining the model that we choose. For example, here, we decide to not create new models. We decide to use existing models. Not because we don't know how to make a model. We know exactly, perfectly how to make a models. However, the best, in our strategy, we say if you would like to explain what is the best strategy for a policymaker, the best thing to do is to use something that's already done. And this will avoid for us the explanation why our model is better than the other. And all these type of things we will avoid. So what we done, we took all the existing used HPV models that are in the literature, and we run the simulation for all of them. And in order to compare, and in order to have a good idea, to have strong results, sensitive, strong results that do not depend on the model that we create. So this is what we've done. And we stopped in 2024, where we give the result to the Ministry of Health. So we have Ministry of Health then write us a good letter, very beautiful letter, saying that your job was okay, and we are very happy, and we are happy with you, and so on. So it's why I'm saying that. I explain you that to say that creating things for Ministry of Health is a long journey. It's a long journey that begins years before producing what we obtain. Once you create this place, the place where you have exchange with a policymaker, this place can be used again for other diseases. This is exactly what is happening now. We are working on other diseases because you create this place where you can have an exchange, we can have medication. For example, here for COVID-19, for HPV, what happened after that? UNICEF asked us to analyze what happened during the crisis, during the HPV vaccination. Why you have very few number of people vaccinated? It was something that was asked by UNICEF, who asked us to do it. If something arrived, it's just because we create this place where you have exchange of ideas. They asked us also to work on other type of vaccine, introducing other type of vaccine to Tunisia to make a study. Because you have this place, you create this place, and they understand that what is the role of modeling, what is the role of a giving fact. What does it mean, giving fact? So, mainly what we've done. So we tested the different vaccines, the Ségolène, Cervarix, Gardasil 4, Gardasil 9, based and compared to the baseline of no vaccination. And what we have here is what we call the cost effectiveness analysis. Here you have the gain, the cost, and here you have the delivery cost, and here you have the gain in here you have the cost, here you have the gain in public health. What I call the gain in public health, you run the models, and you look at the number of let's say it in scientific words, you calculate what we call the DALYs. The DALYs is you count the number of, you do not count only the person who died, you count the number of life lost between the person who died and the optimal or the maximum life expectancy. So, and here you have the percentage increase of cost of when we introduce the vaccine, and you make it relatively to no vaccination. So what we observe, here you have the different vaccine that you have, which is Ségolène, Cervarix, Gardasil, and Gardasil 9. When we calculate the cost is for here is the cost of vaccination and the cost of treating the cancer. Each time you have a person who has the cancer, and you counted how the country will pay for his cancer. Each time you vaccinate one individual, so you count the cost of the vaccines. So more you have a person who having the cancer, more you can pay. And more people are vaccinated, more you're going to pay for the vaccines. And if you vaccinate, you decrease the number of cancer. So the question is, how many people you're going to vaccinate, how many people you're going to treat. So what we observe, depending on the vaccine, the best strategy is a strategy that is here. If you compare this strategy, and this strategy is the best one. I will tell you why. It's mainly because this strategy gives you a gain in public health with a certain cost. For the same gain, you have a higher cost, and this one you get a higher cost. So for sure, you will choose the one with a low cost compared to the gain that you obtain. So all the strategies that are inside this curve are bad strategies. What are the ones that are in this curve are the good strategies. Then you can compare between, if you look at this strategy, and this strategy, you can see which one can be a good one. So let's do it together. If you take this strategy and this strategy, which one can be a good one? So you can say both of them are acceptable. However, if you look at what we call the marginal cost or the marginal gain, the marginal cost, the marginal gain is what you gain or what you pay when you increase one unity of vaccine or one unity of gain. I will explain you that. Let's suppose you have a car. You buy a car and you have, I could say, four power car, and you buy it by $10. I'll say $10,000. And then you have the other car with 6 power, and the cost of this is $20. Do we need to pay it or not to pay it? Do we need to buy it or not to buy it? So I will say the question differently. You like to buy a car. You have two different of car. You have one with 4 power and the other one with 6 power. The one with 4 power, it costs you $10,000. And the one with 6 power costs you $20,000. Which one you choose? The 4 power or 6 power? I will explain you how to do it. This is a problem of marginal cost. What is the cost of 1 power for the for the first car? Is 10,000 divided by 4. What is the marginal cost? What is the cost that you will pay for additional power? Is 10,000 divided by 2. Because you will add 10,000 and you will add 2 power. So the additional cost is quite high. Now if you, the same car, the 6 power car, instead of paying it $20,000, you will pay it by $11,000. What will be the additional cost? The additional cost will be 1 divided by 2. And you see that in this situation, if you buy it by, if the second car will cost you $11,000, it's better to buy this $11,000 car than the one of $10,000. Because what we will gain, your gain will be higher if you than the other. It is exactly what we have here between this and this one. What I explained to you is look at the derivative between the cost and the gain. If the derivative is less than the first derivative, then this strategy can be better than this one. Because the cost of the gain that you obtain between this and this one will be less than the cost of the gain that you obtain here. Now if you do the same thing between this one and this one, if you look at the gain, the benefits in public health here is very small. However, the cost is very high. So what you will pay more for the gain in public health will be very small between than this one. The cost that you have to pay here is all this derivative is very high. So the best strategy is this one, or this one, depending on it. And then you give this to the policymaker. So here you have two governance perspective, here you have societal perspective. So what is the difference between governance perspective and societal perspective? The societal, when you speak about societal perspective, you speak about the cost of the cancer, the cost of everything. Whatever the person will pay. When we speak about the governance perspective, you are speaking about the governor who will pay. For in our countries, generally the citizen, the people pay for for the hospitals. Government pay, but also if you go to private sector, you pay the individual who pay for that. So you need to take these two perspectives. Who will pay, government paying or societal paying? Vaccine sometimes is paying by the government, and hospital is paid by the individual. So, what we said here is, for example, it's the best strategy. What Tunisian choose strategy is the second, which is this strategy, the less expensive one. Then we went to another point of view. You like to say, well, let's try to see the effect of cancer screening. And knowing that we have vaccinated, what is the best strategy for cancer screening? For that, we compare our current situation. We have a pass-mark test. It's used in every low coverage rate in Tunisia, right? And the goal is to introduce a rapid test, which is the HPV DNA test, starting in 2030. The baseline is no vaccination, maintain the current screening strategy. And we want to test these scenarios. Scenario 1 is vaccination plus current screening strategy. Scenario 2 is vaccination plus one-time test strategy. Scenario 3 is vaccination plus test twice in lifetime. And scenario 4 is vaccination plus test in 5 times over the lifetime of the woman. The coverage situation, and we tested different coverage situations. 15%, 25%, 33%, 50%, and 70%. This is what you obtain. This is the cancer case. This is the HPV test. Sorry, this is the HPV case. This is the cancer. So what you observe is the screening have almost no effect on the HPV, which is quite normal. And however, if you look at the yearly cancer case, what we observe is depending. This is no vaccination. This is sorry. It is no screening. This is screening. This is scenario 1, scenario 2, and scenario 1, 2, 3, and 4. So what you observe, if you take scenario 1, 2, and 3, you observe that the curve will continue to increase, and then we're going to observe a decreasing in the number of cancer cases. So it means that for policymaker, it's very important for him, because he knows that even if he introduces the vaccination, and even if he will introduce the screening, the number of cases will be continue to increase into 2035. And then he will observe the decreasing value after that. The second thing that is important here is if you look at all of them in 2100, all of them will have the same effect. If your horizon is 2100, whatever strategy, all of them will work. And why all of them will work is mainly because you have vaccination. Because in 2100, you're going to have all population to be vaccinated. So you will not have cancer. So the screening will have no effect here. So this is something very important. It will give you, when you are dealing with this type of things, you need to decide what is your horizon where you will evaluate the cost and the effectiveness. Your horizon is it gives you a huge difference. So if your horizon is 2020, oh I know, 2100, so all of them have the same effect. However, how do you arrive to it? Arriving to it, if you look at the different curve, the best one is this one, which gives you is the scenario 4. Scenario 4 is testing 5 times lifetime. The decrease will be stronger than the other one. And as the decrease is stronger than the other one, the number of deaths that you will obtain, the sum of the number of deaths that you obtain in 2100 will be lower than this one, this one, this one, and this one. So this idea, you need to say it, calculate it, and you give it to the policymaker. For example, in our case, when we explain this to the Minister of Health, his point of view totally changed. He could not imagine that the effect, he will see the effect in 2100. He could not see that until 2035, he will not see any change. And his perception of his strategy changed totally. He said, well, I'm not, he said, I give you what he said exactly. Say, we are not working for now, we are working for next generation. When I will see the effect of the vaccine, I will die. I will be died. Exactly this, and it's very important for him, because he knows, as a politicalist, as a politician, he knows if he can use this fact for himself or for future generation. What is the message or the communication message he will need to give it? And it was done. I mean, the message that was made in Tunisia is vaccinate your girl in order to preserve your girl. Not vaccinated your girl in order to preserve the population, which is quite different. The vaccination, you use the vaccination in order to preserve the individual and not to preserve the population. This is the message that we want to give. So then we made the same idea. We use the same idea and use it in Senegal. We just and in Senegal the scenario was quite different. is the current situation based on historical. They already have vaccination in Senegal. So the first scenario is the current situation. It's based on historical vaccination patterns from 2019 to 2020. Scenario 2 is a moderate increase. Scenario 3 is 90% coverage, and for the first dose and in alignment with the WHO. And you use the same idea. You use UNIVAC tools, but you also HPV-C models. Same ideas, using already known models, well-known models, in order to explain to the policymaker. So it is easier for him to understand. And here you have the result. 1 dose, 2 doses, and so on. So Ministry of Health like this table. They like the graph, they like diagram, but they like better more this type of graph, where you have a different strategy and different and all the results. So this is what you obtain. Same cost-effectiveness analysis. What you observe here, if you look at here, you have you can see it. Here you have 0. Here you have negative values. So all the strategies that are here are really cost-effective. If you vaccinate here, or you have with all these strategies, you are beneficial. You gain money for policymaker. So it's better for policymaker to use this strategy because he will have more money than vaccinating this strategy. It's a really very good strategy. Then, as I said, our goal was to try to understand also the perception of the vaccination. So what we've done, we made a qualitative studies in 2024, and to try to understand the perception of the opinion of the people against the vaccination. And for that we use healthcare professional, community professional, with midwives, gynecologists, pharmacists, pediatrics, parents, school teacher, and making them all region of Tunisia. And we analyze it. And we had a lot of concern. We had concern about cervical cancer, risk, effect of fertility. I don't agree to vaccinate my daughter. Of course, since the issue is related to reproduction of parents, we'll avoid this vaccination. A mother from Janduba expressed that the idea that authority vaccination girls, so they won't have more children. So some ideas that it's how can I say it? Religious idea, traditional ideas, wrong ideas, quality of the vaccines, lack of collaboration is not our priority, stigmatization. This is the idea that emerged from what he said. So it's important here also because we are after COVID-19 situation. So this is the opinion of people against HPV, but not only is opinion of parents after COVID-19 crisis, and COVID-19 crisis of vaccine, which is very important. What we've done to try to analyze this one, we analyze it using EI and transformer-based natural language clustering to try to make the emergence of different opinions that we obtain. And I don't have here the results, but we were able to to make this qualitative analysis into quantitative analysis, to giving a cluster of opinion of people answering the same way. And one thing that we observe also is medical doctor are quite different than are more medical doctor and person from the south, from this part, are more against the vaccines. but not more against the countries, decision from the country. They accept the decision that was taken, but they are a little bit against the vaccine. They are more relatives. So Baya, who is the one who conducted the survey, so you have any question, you can answer to, I think Baya can answer to the questions. It's very interesting. So anyway, I will stop here, and thank you for if you have any question, I will be happy to answer.
I have a question regarding the COVID-19 strategies.
Yeah.
Regarding the COVID-19 strategies that were employed by different countries, is there a way that we can try to find out the effectiveness of each of these as we prepare for any future pandemics? Like you said, in Tunisia, they decided to do nothing. Yeah. In my country, they locked us up for many months. Yeah. I mean, going backwards and looking, can we try to find which would be a better strategy if COVID-19 came back?
Yeah, thank you. It's a very good question. A very question that we try to answer. I have no. I will not give you the answers that we did not finish the studies. But what we discover it depends on the time horizon. When you say best strategy, what is the best strategy? It needs to take two things. When you stop, because when you stop, you will stopping. If you say that I will go to the end of the epidemic, which is 2023 or 2024, when you have no more cases of COVID-19. I mean, and then we evaluate what the benefit of the different strategy, benefit in terms of public health, but the cost of them. And the cost need to be taken by the cost of the vaccination, the cost of the disease, but also the cost of doing nothing. What we lost if you did nothing. But also you need to take into account, if you look at the countries that closed everything, like China, like Australia, they closed the countries. But they needed to pay the cost of closing the countries. But also they needed to pay the cost of opening after that. And now opening after that, they had the epidemic. They had the first wave, a certain number of waves that happened after that. The only thing that which is the best strategy, I don't know. I think it depends what in our study gives that the best strategy also depends on what we are able to pay. If you are not able to pay the cost of closing, the cost of having a new wave after the COVID, so even it's a very good strategy, you cannot pay it. So my question is that's why I say that for Tunisia the good situation, the good strategy was to do nothing. Other questions? No? Okay, thank you very much.